back to you, Michael.
Awesome. So next we have Simon Collins. And Simon, if you want to give us a quick introduction of yourself, and you will be able to present your own slides, I believe. So unless you have difficulties with that, then we can do that for you.
So thanks for the invitation to talk. Fantastic workshop, fantastic turnout. See everybody here. I'm a treatment advocate that works at an organisation called HIV iBase in London. I also get involved in various research groups. So I've been involved in a study called the Rio study, which was just about to enroll as COVID-19 hit last year. And so I'll mention a little bit about that. And otherwise, I've come to most of these workshops. I'm very interested in cure. I'm HIV positive, and I've been on treatment since the mid-90s, I think. So, slideshow, sorry. I'm not very technically competent. Okay, so the thing I would guess I wanted us to remember through the talk is that how just how unexpected the pandemic was last year, and just worryingly how much it's normalized and how much we take things for granted. That really, if we talked about last January, nobody would have expected that international airports and travel would have been closed, that the US government would be sending a check to all citizens or most citizens, that this seed of an epidemic, the seed of a virus would infect 115 million people and cause 2.5 million deaths, roughly, and the governments would be borrowing trillions of dollars in order to sustain the economies. And yet all that's happened. And there's also been good surprises, because most of the way through last year, vaccine experts were talking about the difficulties of getting a vaccine and questioning whether we could get a vaccine within a year or 2 years or 3 years. And vaccine efficacy back then was spoken about 50%. And so we can have good surprises as well that radically change the circumstances that we're all working in. And the impact on every country where COVID-19 became a serious issue. And there are some countries where COVID-19 they haven't had cases yet, but they tend to be small islands. It was really that even if you were doing the research, that question about whether you continued research into cure research, including whether it included a treatment interruption or not, meant that it wasn't always a direct question that you were in charge of. The resources were diverted on a major scale in the UK and most other countries. So clinics, HIV clinics were closed, regular clinics were closed. If you'd been diagnosed with a cancer that needed an operation or treatment, that was stopped. This is unheard of. Most laboratories were shifted to deal with COVID-19. For HIV care, nobody got CD4 count tests or viral load or resistance tests. Lots of HIV the HIV sector played a huge impact in the response to COVID-19. Many doctors and researchers were transferred into coronavirus, and even examples like HIV home tests were being recalled and repurposed so they would test for coronavirus. And then within that, if you did have an element of choice for whether you would be continuing a cure study that involved a treatment interruption, you would have safety concerns that would be related to increased traveling at a time when many people were being shut down, visiting clinics when clinics were seen as one of the main places where you could catch coronavirus. So many cure studies, by definition, there's no way we can tell someone's cured other than by taking a treatment interruption. There's no surrogate marker data that tell us whether something's likely to be successful or not. Pose specific challenges while COVID-19 is going on. And the ATIs that are now being used are not short week or two waiting for detectable viral load. They're quite often looking for much longer treatment interruptions, maybe months, maybe up to a year. so the compounds in the Rio study, if they work, we'd maybe be asking people to be off treatment for 6 months or 12 months. You'd be making these decisions about restarting studies or holding treatment interruption studies with really limited data. We were only just getting information about how coronavirus was transmitted, but these decisions were being made, the research teams I'm aware of, were being made with large amount of community input. So as a community rep on one of these studies, it was important whether I thought this was a risk that was justified by the research, or a risk that really shouldn't be taken by any participants. And then making these decisions about, so all through last year, the research groups were discussing whether it might be possible to restart these studies or to initiate studies. And you became aware that you'd be making a decision at a time which seems relatively safe. Maybe there'd been no coronavirus, the coronavirus numbers had stopped altogether. If we were on a conference call to someone from Australia, they would say our borders are shut. We have no coronavirus. We could run a treatment interruption study here. There was always with the understanding that it could be a very vulnerable decision, because if a new infection occurred, within a few weeks you could be in lockdown. So like here's an example where you could maybe have low COVID rates for several weeks or several months even, and you make a decision as a research group that it would be safe to allow participants to enter a treatment interruption study, but then within a few weeks, coronavirus would rebound. And then for those participants that had safely undertaken a treatment interruption, I think the plausibility is that they would be at increased risk of serious outcomes if they didn't restart HIV treatment. And if they did restart HIV treatment, then you've lost the data that you were looking for from having a treatment interruption study. The limited data that any of these decisions would be made under would mean, I mean, it seems ridiculous now. If you think back, there were months where people couldn't decide on whether masks were effective at reducing transmission. There were different approaches to social distancing and different approaches to risk within hospital settings. If an HIV clinic was still being run at a clinic where COVID-19 was being treated, you would intuitively be cautious about the increased risk of catching coronavirus. There's limited data still on the impact of coronavirus and HIV together. But most of the guidelines that are out there looking at care for HIV positive people emphasize the importance of being on ART, or at least hope that people on ART with a good CD4 count and undetectable viral load might not be at any increased risk. As the year went through, actually, risks were being reported from larger powered database studies that showed there was an independent risk associated with HIV. The known risks of coronavirus and COVID-19 when in the early months of last year were assuming this was a short infection, that 80% of the population maybe wouldn't need to be hospitalized, and that within 2 or 3 weeks everything would be resolved one way or another, even though the outcomes could be really serious. And now we know that long COVID is a much more serious issue. So running a study where you increase the risks of people getting coronavirus during a treatment interruption might have really long-term consequences. And then we were also having these discussions at a time where COVID-19 might be something that was going to run for 2 years or 3 years or 4 years. If a vaccine didn't come along, then the implications of stopping all cure research for 5 years became much more serious. So over this period, 2 of the research groups, both of which had really good input from community, published discussion papers about the safest way to run a treatment interruption during COVID-19, including ways to reduce any risk, but also looking at the ethical questions about whether these studies could still be justified. Sorry, I should have said the top paper was mainly from a US group, and the bottom paper was mainly from a UK group, but with became an international collaboration as well. So in the US study, and there was a good overlap between both the discussions. It sort of started with the serious principle is that cure research is important. It was mentioned earlier that a third of the population don't have access globally to HIV treatment yet, and looking forward, the outlook for 40 million people is a serious one, where achieving a cure would make a huge impact. And then the papers were looking from the perspective of reducing harm if these studies continued, and also following research into COVID-19 in case that changed. The importance of informed consent to participants was critical in both papers, and it really involved rewriting the informed consent to make sure that COVID risks would be addressed directly. So the US paper, in terms of looking again at exclusion criteria or inclusion criteria for going into a cure study that had a treatment interruption, would look at maybe cutting back people whose risks for COVID-19 you already know are very high. So the easy ones to decide on, or to agree on, I guess, was that people who are older than 65 maybe shouldn't be going into an interruption study at the moment. If you had serious comorbidities, and some of these were listed because they'd been reported in COVID studies, some question marks about smoking and vaping, whether that would be something you'd want to use as an exclusion criteria if you were taking a treatment interruption. And then the issues that are reported as seriously impacting your risks from COVID-19 that weren't included in the paper was race and occupation and social situations. If you live in mixed housing, or if your partner works in healthcare, whether that would be enough for you to be excluded from a ATI study. And this paper didn't find that this was a good thing to do. Changes to the study would include reducing the number of hospital visits, using telemedicine, so that your risk from traveling to the clinic are reduced, and then maybe providing taxis and masks. This paper was published really early in JID, and you can see that the discussion then was about whether we should be providing masks. Lots of talk about SARS testing, which was developing during last year. Important that you would be tested at baseline and during ATIs to find out whether you were positive. And the assumption is that if you were positive, you would restart ART. And to be aware of changes in local COVID incidents. So if the risk started to increase, if the incidence increased, then maybe the ATI study would be adapted. Lots of question marks really about the potential social impact that would happen from being part of a study, and making sure that this is covered in different populations. So the UK study, which started out as a project from the Rio study, also looked at the ethical issues, the risks and practical factors that we could do to minimize risk if we got to the stage that a treatment interruption study could be restarted. Again, this was based on the importance of cure research and establishing that the research is important enough to make sure we could do everything we could to re-establish the research if COVID-19 proved to be something that continued for years. In the Rio study, we are hoping to interrupt treatment for more than 6 months. We use 2 long-acting monoclonal antibodies where in people who started treatment very early, and people will be randomized to either get the antibodies or the placebo. And we're hoping that these antibodies would generate a time off treatment, which is maybe more than 6 months. The study, if you're looking to generalize about cure studies and safest ways to do it, we decided, there was agreement really that this has to be individualized by study and by region because the differences are so dramatic. The point that was also made in the US paper. And then efforts to minimize the risk of catching coronavirus would be to take down the number of hospital visits, with a concern that if you did become coronavirus positive, that the increased inflammation from having HIV and coronavirus at the same time could easily lead to worse outcomes from the treatment interruption. It could lead to worse outcomes from COVID-19, and big caution as well, particularly if you're looking at international studies, but even in the UK we were going through Brexit at the time, is the idea that you might stop treatment and somebody comes to restart it and the treatment isn't available anymore. Again, we summarized potential approaches in a table, limiting high-risk groups for entry criteria, expanded access to coronavirus testing to check you're not positive at enrollment, limiting clinic visits, looking at home sampling. Actually, a lot of these things that intuitively should be easy to arrange were quite challenging to do in the UK NHS system. Flexibility again to local changes, updating and revising patient information to make sure that the risks, as far as we knew them, would be clear to participants before they enrolled. And then we also had time, this paper came out a little bit later, to add some paragraphs about approaches when vaccines became available and whether or not, it brings up interesting questions, whether or not as a research group you'd want to make vaccine protection part of the entry criteria in order to be included with the study. So as a vaccine update, the rollout of vaccines and availability of vaccines. Most countries, most Western countries have got access to several vaccines now, but this clearly isn't equitable globally. And so if there's international cure-related research, the assumption that everyone's going to have access to vaccines isn't going to be true. We are interested in whether, and what you think about this as well in the discussion, about whether ATI studies should also include vaccine cover. Maybe the studies can provide vaccines where this isn't normally available, whether you define that you'd need full protection from both vaccines for a study to start, or whether minimal cover from one dose would be okay. And then to also be aware in the changing incidence of variants. So you might have been vaccinated before going into the study, but by a vaccine that wasn't protective in variants that then occur later. So in conclusion, I suppose I'd like to emphasize that HIV research has responded rapidly to the new changes that came from COVID-19. And this was very definitely from a perspective to prioritize patient safety. There's a continued commitment to doing this research, and that restarting studies, I mean, to wrap it up nicely, is the Rio study is looking to restart in the next couple of months as UK vaccine coverage is now standardly rolling out to HIV positive people. I'd like to thank a few colleagues for help with slides, and I'm happy to take questions.
Thank you, Simon. That was a great overview of our recent past. I was just, when you started, it just reminded me that a year ago, this very workshop is right when it seemed everyone was frozen. CROI was being held and everything switched virtually. And that was a year ago when we had all of that happening here. And I just sort of made me take a pause and think it's been officially now a year since my life and probably lots of people's lives have been affected by COVID in that drastic way. There's a conversation that's going on in our chat, and someone wanted to say that haven't the vaccines made all of this moot now, they were saying. And so there's been a couple bits of discussion with that, but I don't know if you might want to comment on that. They were saying that vaccines made all of this moot.
Well, you have to have very good vaccine coverage to say that. I don't know of any country that's done that. and then you're still going to have issues that will be vulnerable. That you could do this, you could have great coverage with a vaccine, and then there's suddenly a variant which is not recognized by the vaccine. And so internationally, if you join some of the WHO webinars on vaccine access, you can see that even with the best plan, the WHO are planning to vaccinate 2 billion people maybe within 2 years. This is going to run with us for a while, and so we have to be flexible about how we ensure participant safety, I think. And that we have to, both the papers that came out will have to be like working documents, because they'll have to respond to changes in local and national epidemics.
Thank you for that, Simon. Linda D has her hand up. Linda, please come off mute and put your hand down.
Okay, I will. I promise to put it down when I get done talking. Yeah, thanks, okay. Simon. That was great. And Mark, you raised this issue. The thing of it is, right now, the CDC doesn't recognize people with HIV for prioritization, and only like 13 or 14 states in the United States recognize people with HIV as being, at increased risk of severe COVID. So, that is hardly good coverage across just our country. And just if, the president keeps talking about, well, summer, May, we're going to have vaccinations for everybody. Vaccinations sitting in a warehouse doesn't mean they're in people's arms yet either. I mean, that's a whole nother giant task. So,
indeed.
And that's not to say anything of the different, the different variants that Simon alluded to. So we got a long way to go here. So we still really need to be careful about, you were asking people with HIV to stop their medications in the era of COVID. So we want to be sure that we don't hurt anybody and that people know exactly what they're getting into before they decide to either get in one of these trials or stay in one of these trials. So thank you. Great job, Simon.
And Linda, just to add to your point, we don't even know if the ATIs themselves may have some sort of lasting consequences for people, let alone adding COVID into the mix.
And further, at what time point during an ATI are folks expected to get vaccinated? If the opportunity presents that they can even access a vaccination.
So on that,
go ahead.
Sorry. So on that, the emphasis would be to have the vaccine before you go for the ATI. So the only reason that the UK study is considering reopening is that people will be able to have a vaccine before they're anywhere near an ATI. You wouldn't want the vaccine afterwards. You'd need it. We really want that protection beforehand.
I'd agree with you. I think there were some other immunologic considerations for folks who may not have access to the vaccine prior to enrolling in a cure trial. But if they were already enrolled, at what point during the study, depending upon the study schema, would they be able to safely access a COVID vaccine, just given some of those social considerations?
I think it would depend on the intervention. So I think there's real caution about vaccinating when you have got a monoclonal antibody. If you're on a long-lasting monoclonal antibody, then vaccines is one of the few areas where you might question that. And Danielle, what would you think about making vaccine cover an entry criteria?
I think that's one of the questions that folks are also adding to the chat. I think, there has to be a system of equity in place before we can ever get to an entry criteria that will require someone to be vaccinated. In the social and lived realities of individuals, that may not be logistically possible. So I would hate for, something that is rooted in good to be a preventive measure for folks to actually access the benefit of science. So we have to weigh the good and the bad here.
Mm-hmm. Absolutely.
Mm-hmm. And there's another question that was asked. Someone was asking, how might the vaccinations potentially affect the outcomes of the ATI or of the study? Do we have any idea?
That is a great question. Simon, what you know? Tell us about it.
So long as you had the vaccine beforehand, there's no reason to see it as any different to having a flu shot beforehand. And I hate making the flu comparison because it's completely different infection. But that sort of, you know, vaccinations are a routine part of life. If you had a travel vaccination, it wouldn't stop you going into an STI study, an ATI study. I'd be interested in, I mean, it's such a great group here. So one of the things that one of the controversial bits that came out in the papers in terms of suggesting changes in entry criteria to minimize the risk of, minimize participants enrolling who are at higher risk of COVID-19, it stops short of recognizing the increased risk based on ethnicity and employment and housing. And I know there was big discussions in both groups about whether that's, you know, where do you draw your line for equity? Should your line for equity be to enable you to join research studies, or should someone be making a decision on your behalf based on your higher risk of serious outcomes if COVID-19 became an issue?
Whoa, lots of ethical considerations, Simon. Very provocative discussion. Linda G
Hi, it's
has
Mark
her hand
Milano.
up.
Can I add something?
Sure, Mark. Let's give Linda the floor since she raised her hand so nicely, and then we'll chime in. I promise we'll come right back to you.
You know, I also wanted to say that we have a study at the DARE CAB that took us 2 years to get up. It's half enrolled. So we spent, I can't tell you how much time deciding when people should be vaccinated. You know, it's not like you can say, okay, I'm getting vaccinated tomorrow. It just doesn't work that way. The other thing is that, you know, we didn't want to throw all of that effort out the window. And certainly we're leaving it up to people, whether they want to stay or go, or, you know, restart and just get the hell out of there and not even go out to visit anybody, you know, to have their hospital visits. But, you know, I mean, there are a lot of studies that are already open. So we have to remember that too. It's not just we can say, okay, vaccination first. I mean, the other thing, we had very, very rich discussions about Simon's ethical questions. And what I tried to recommend was, instead of, you know, we want to be cognizant that certain ethnic and racial minorities have a higher risk, but we also wanted to have, you know, let them decide. But we tried, and this is what I recommended, tried to make sure, and we really had a dance around with the investigators who ended up taking every one of our recommendations to try and make the exclusion criteria such that anybody that had levels that would put them in any danger that we know of, you know, were excluded from the study. So we kind of did it that way. And instead of looking at classes of people, we looked at individual, you know, metrics as far as what kind of shape you were in.
So both papers were very consistent in terms of the importance of informed consent.
Absolutely, right. This process is about autonomy. Thank you for that. And thank you, Simon. Mark, are you there? As promised, please come off mute.
So I'm painfully aware of vaccine apartheid, so much so I'm organizing an action on Thursday in New York City, particularly focused on this issue. So yes, of course, the majority of people around the world don't have access. And you shouldn't require someone to scramble and get a vaccine before they enroll in the trial. My point was that it would certainly seem to me that people running clinical trials could say, we feel that people with HIV enrolling in a clinical trial should be prioritized for vaccines, and we're going to give them vaccines. And they should work with governments to say HIV cure research has to continue, it's important. So we need vaccine supplies to give to our participants when they enroll in the trial, which, I mean, I'm also painfully aware as a person with severe kidney damage, how dangerous it is for me to leave my house and go to the doctor, or I would never enroll in a clinical trial because it would be just too risky for me. So my point was just that the trials themselves should negotiate to get COVID vaccines and to say, anybody joining this trial, we will offer you a vaccine, which is also an incentive to get people to join the trial. That's the point I was making.
Gotcha. And so, Mark, just to bring other ethical considerations into the foray, would, you know, the incentive to offer folks a COVID vaccine be viewed as coercive?
Oh, I don't want to even go there. I disagree, but I don't want to go there. I think if you're taking a risk to go to join a clinical trial, taking a risk to go to a hospital or risk your life, to say, you know, we're going to offer you a vaccine to protect you is the same thing as saying we're going to mask up, we're going to do all the things that we do to protect you while in this trial. And one of those things is to offer you a vaccine if you join the trial, which is the best protection of all.
Right.
Very interesting point.
We also have a question.
Go ahead, Michael.
The data, whether it's safety data, as Hannah was bringing up, or just other data that they're collecting. How is it possible that the results of all these halted trials are going to be reliable? Especially if they had sort of, you know, like I know from clinical trials, they always have these points where you have windows where you have to have something happen or else they're out of, you know, lost to follow up, or they are out of the study's bounds. How is it that these results, if you had an intervention and you wanted to see if it was having an effect and all of a sudden you're on halt, how's the data going to be worked with to become reliable or to be trustworthy? Are we going to be able to trust it, or do we just need to scrap some things and redo them?
What do folks think? Simon, you're the expert.
I'm sorry, I was responding to chat.
We're all over the place.
I got caught out on that
Michael?
one. Sorry, what, can you summarize the question again? Sorry.
About the data in all of these trials, whether it's an ATI trial or another cure-related trial, they've all been stopped because of COVID. And how is that going to affect data, whether it's safety data or other endpoints that they were trying to collect?
So I think it's really difficult. I think there's a post from Thomas here where he was in the middle of an antibody study, it got stopped, and now it's not going to restart because of lack of supplies. I think any study that got stopped because of COVID-19, the data is going to be very limited. And there's been some really, high profile studies that just about scrape by. We've been talking about long acting injections, the Cabenuva study just about got through, but it stopped early. And then some of the big prevention studies, the injections for prevention, also stopped because they recognised that it wasn't ethical for people to still be coming to clinics during this time. And so you're either lucky and you scrape by and you had a result which is still statistically significant if you were lucky, but otherwise I think a considerable amount of HIV research will just have this block of missing data. And the statisticians will probably model a way to replace it.
Say more. Thank you. I was going to try and sneak it in, but I think you hit it. Linda D, come off mute, please. I see your hand.
Yes, just real quickly. In a lot of these cure studies, the big one that we were talking about at DARE only has 15 people in it. So if the first 5 people, everything was so confounded, they couldn't make anything out of it. If they reopened it, they could get 15 more. You know what I mean? So we wouldn't have to reinvent the wheel and start all over again. But for a lot of other stuff, I mean, that's an excellent question, and I think about it all the time.
Great point.
And this is Richard, if this is an okay point to jump in.
Sure, go for it.
Just to address Mark Milano's point about providing vaccine, I think that is I think those discussions are happening locally and will be partly guided by what's happening in those jurisdictions in terms of whether research teams can get access to a supply of COVID vaccines for the study population. And I do think William, who's going to talk next, may be able to talk a little bit about that. I think they may have been able to get access to vaccines in Philadelphia.
Mm-hmm. Mm-hmm. That's a great segue, but really quickly, Linda, did you have another question? I see your hand up.
No, I'm sorry. I'll take my hand down. Sorry.
Okay, cool beans. No worries. Want to be sure that we are responsive to folks. Are we good to, Karine Dubé, come on off mute, Karine.
Yeah, I'm wondering if we have a biomedical researcher who is now weighing the risks and the benefits of the COVID vaccine amidst therapeutic interventions on the webinar, who may want to weigh in.
It's a great point. Is there someone on the call who's a biomedical researcher contending with this very lived experience? I would hate to have to search the field of participants and call you out directly. I'll do it.
I'm happy to talk about it. I just was waiting to get, I'm doing my Southern lady polite, waiting for other people to speak up.
Floor is yours.
I think these are just fantastic questions. And in fact, this is one of the, this session in particular is one of the reasons that I wanted to attend this workshop, because we are grappling with this right now. Katie Barr and Simba Takuva, Lucio Gama, and I, among many others, are grappling with this for 2 ATIs that we, one of which we had already opened literally 2 weeks before everything shut down, and the other was very close to opening, being conducted in the US, South America, so Peru and Brazil, and in several countries in sub-Saharan Africa. And so we are now going back and actually doing pretty extensive consultation with community representatives that we've done. We've had 2 stakeholder meetings in each region in the last 3 or 4 years while we were developing these protocols. And we are going back to those folks to talk about how to integrate the COVID considerations into these studies, working with regulatory and ethics committee representatives and the ethicists on the protocol teams. And we've been grappling with a lot of the questions that you guys have already identified. How can we, as we always do in ATIs, mitigate the risk of participation while still addressing the urgent scientific questions that they ask? And I would say that actually COVID has given us another opportunity to dig a little deeper into, okay, is this study or these 2 studies, are they answering unique and uniquely pressing scientific questions that really do justify potential additional risks in the era of COVID, and then how can we mitigate those risks? So I think it's good for us to continue to ask ourselves those questions, continue to question the rationale and the potential value of the studies. I personally am a huge supporter of providing COVID vaccination to these participants, but not requiring them, because people have different, perceptions and personal values and risk calculus to do for themselves. But I do think that we should be in a position to be able to provide vaccines. I really do like the question of, is that coercive? And I hope that we will soon, in many, if not all of these countries, be at a point where it's not coercive because it is truly available outside of the clinical trial as well. But maybe we can reduce the number of hoops that people have to jump through, or perhaps even the wait that people have to endure before they can get it. Yeah, I don't think I've covered at all the breadth or the depth of what we as a team have been thinking about or what you guys have just discussed, but essentially everything that you guys came up with, we're grappling with as well. And some of the references, Simon, that you used in your presentation that are written by people with whom we're consulting and are themselves providing some really useful context for our thought process.
Thank you for that, Shelley. Great perspective. Happy to hear from you on this. And, it draws great synergism to the discussion that we're having today. So, this is really a community stimulated dialogue, and